Hello, everyone. Welcome to PodBites, where we break down complex medical topics into bite sized pieces, perfect for your commute, coffee break, or whenever curiosity calls. I'm Leen Hakki, your host for today's episode, and I'm joined by Farah Alrab.
Hi, everyone, and thank you, PodBites, for inviting me into your beautiful office. Our listeners can't see, but there really are a lot of pairs. In this episode, we're going to discuss the treatment of one of the diseases we discussed last time, arthritis, joint inflammation that causes many people around the world a great deal of pain. So let's hop right in.
Let's get started with our first case. So, Farah, we have Arthur, a 58-year-old man who presents with a 6-month history of joint pain and stiffness. He reports that the stiffness is worst in the morning, lasting over an hour before his joints loosen up. The pain began insidiously in the small joints of both hands, particularly the MCP and PIP joints, and has gradually become symmetric. He now struggles to button his shirt and open drawers. He also notes fatigue, mild weight loss, and occasional low-grade fevers. What do our labs and physical exams show?
On examination, Arthur has tender, warm, swollen joints in both hands and wrists. There is early ulnar deviation and mild swan neck deformity, developing in a couple of fingers. No DIP involvement is noted. Investigations show a positive rheumatoid factor as well as positive anti-CCP antibodies. He also has elevated ESR and CRP, which are our inflammatory markers. And an X-ray shows periarticular osteopenia, joint space narrowing, and marginal erosions.
This presentation is highly suggestive of rheumatoid arthritis with systemic small joint involvement, prolonged morning stiffness, systemic features, and classic serology. Though to be honest, the swan neck gave it away for me.
That would be a key word to keep in our minds. This condition is quite gnarly. Luckily, there are many treatment options to give our patients, each with their pros and cons.
So without further ado, let's hop right to the one we probably all already have in our medicine cabinets, ibuprofen.
A prime example of the classic NSAIDs or the non-steroidal anti-inflammatory drugs, which work on inhibiting the COX-1 and COX-2 enzymes, decreasing prostaglandins.
Ultimately, this means less pain, less inflammation, and less fever.
Considering that it's those that cause the most inconvenience to our patients, this drug is a relief. Though we need to keep in mind that NSAIDs do not slow the disease progression. There is zero effect on the process that causes rheumatoid arthritis to begin with.
And it wouldn't be a pharma episode without some side effects. So could you tell us some of those?
To understand the side effects, we need to know the two sisters, COX-1 and COX-2, and what they do.
That rhymed. Anyways, we know that COX-1 is the protective older sister. She works hard to make sure no one scribbles on the walls or the lining of the stomach. She also helps in maintaining platelet function and kidney perfusion. COX-2, on the other hand, is the wild younger sister. She shows up when there's drama or inflammation.
And you can take a wild guess as to what happens when we inhibit COX-2, but when we do so, we also block COX-1. So the stomach is no longer protected, increasing the risk of GI ulcers.
Why don't we just block COX-2 then?
I mean, you could, but then the risk for an MI skyrockets in those with already existing cardiovascular disease. I don't think anyone wants to be told that the side effect to their arthritis meds are a heart attack.
But how does that happen?
You mentioned that COX-1 maintains platelet function. It makes thromboxane A2, which promotes platelet aggregation. On the other hand, the rebellious younger sister makes prostacyclin, which blocks platelet aggregation. If you block COX-2 only, you lose prostacyclins, so thromboxane is unopposed. Platelets party, clot risk goes up, hello myocardial infarction.
So we would avoid selective COX-2 inhibitors in those prone to cardiovascular disease or myocardial infarction. What about the kidneys?
NSAIDs and a low GFR equals disaster waiting to happen. They can cause acute kidney injury, hyperkalemia, sodium retention, and worsen heart failure. So in chronic kidney disease patients, we think twice, then think again.
All right, so for NSAIDs, we've got the selective type, blocking only COX-2, and the non-selective, which blocks both. Ibuprofen is a classic example of non-selective, and aspirin as well as naproxen and diclofenac. We want to avoid using non-selective due to the GI effect, especially since we're dealing with a chronic condition, meaning they'll be taking them for a long time. All right, Farah, moving on from NSAIDs, let's talk about glucocorticoids or our bridging therapy.
Glucocorticoids are strong anti-inflammatory and immunosuppressive drugs. Their main mechanism of action is inhibiting phospholipase A2. So you shut down arachidonic acid, prostaglandins, leukotrienes, so the entire inflammatory cascade.
And why do we call them our bridging therapy?
Later on in the episode, we will cover DMARDs, or disease-modifying anti-rheumatic drugs. The issue with them is they take time to work, so we use the steroids to cover for our patient until they kick in.
Considering the fact that they're steroids, we keep hyperglycemia, weight gain, osteoporosis, cataracts, glaucoma, and infections due to decreased cell mediated immunity in mind for our adverse effects. We can also see Cushingoid features, HPA axis suppression, and mood changes. And since it's dose and duration dependent, glucocorticoids are not recommended for long term monotherapy. Ideally, we want to use them for less than 3 months.
And, like with all steroids, we want to taper them down and not stop suddenly. Also, we can use them in joint flares that are particularly bad by injecting them into the joint.
All right, Farah. Before we carry on to discuss the mighty DMARDs, let's take a quick practice question.
All right, here's one. An elderly patient has a history of taking both prescription medications and over the counter painkillers for her rheumatoid arthritis. She is not diabetic and has no history of kidney disease. She is admitted into your clinic in acute renal failure and comments that the pain in her hands has become much worse in the last week. Which of the following drugs is most likely responsible for the adverse renal effect? A. Ibuprofen, B. Prednisone, C. Colchicine, D. Probenecid.
And the answer is A. NSAIDs as a class are associated with renal toxicity. Prednisone is effective in alleviating the inflammation in rheumatoid arthritis, but is not associated with adverse renal effects. Finally, colchicine and probenecid are used to treat gout, not rheumatoid arthritis. NSAIDs help the pain, steroids bridge the gap, but the real treatment for rheumatoid arthritis is DMARDs.
DMARDs are the actual disease-modifying drugs. They slow the autoimmune process, protect joints, and prevent long-term damage. But their effect isn't instant. It takes 2 to 6 weeks, sometimes more, before we see improvement. Hence, the bridge treatment.
We have three main categories of DMARDs: the CS DMARDs, or conventional synthetic, B DMARDs, or the biologicals, TS DMARDs, aka targeted synthetic.
Most are contraindicated in pregnancy because they block purine and pyrimidine synthesis, and we do not want to disrupt DNA synthesis while someone is pregnant. Now, Leen, there are a lot, so let's focus on our first line, methotrexate.
The anchor drug, used alone or with others if needed. Tell me more about the mechanism of action.
2 main mechanisms. First, DHFR inhibition, where methotrexate blocks dihydrofolate reductase, so folate can't convert into its active form, tetrahydrofolate. This results in reduced purine and pyrimidine synthesis and a decrease in T and B cell proliferation. Second, increased adenosine, which is the main mechanism. Hence, methotrexate inhibits the ICER enzyme, so ICER builds up and the extracellular adenosine increases. Adenosine is anti-inflammatory, resulting in decreased neutrophil adhesion, decreased cytokines like TNF alpha, interleukin 6, and decreased overall inflammation.
So methotrexate reduces inflammation from 2 angles, blocking DNA building blocks and boosting adenosine. When students hear methotrexate, what's the toxicity that should instantly pop into their head?
Liver toxicity, always. That's why we check liver function tests every 3 months, and beyond that, we also worry about bone marrow suppression, like leukopenia and thrombocytopenia, plus stomatitis, teratogenicity, and even the rare methotrexate pneumonitis.
And to help reduce some of those side effects, we give folinic acid. Why folinic and not regular folic acid?
Because folinic acid bypasses DHFR. Methotrexate blocks DHFR, so folic acid can't get activated, but folinic acid goes straight into the active form and rescues healthy cells. That's the whole idea behind leucovorin rescue.
All right, quick rundown on pharmacokinetics. Anything important?
Yeah, methotrexate is absorbed really well at low doses, about 60 to 70%. But the absorption drops at higher doses. And once it enters the cell, it gets polyglutamated, which basically traps it inside so it stays active longer. Oh, and one clinical pearl, giving NSAIDs with methotrexate can reduce its clearance and increase toxicity. So that combination needs caution.
We talked about methotrexate, the anchor DMARD. What's the other big synthetic DMARD we should know?
That would be leflunomide. It's also a CS DMARD and is considered the alternative first-line agent when methotrexate can't be used. Think of it as methotrexate's cousin, similar efficacy, but methotrexate is still preferred.
What makes leflunomide special?
It's a prodrug converted into the active metabolite, teriflunomide. Its mechanism of action is that it inhibits dihydroorotate dehydrogenase, which decreases pyrimidines, which decreases T and B cell proliferation, resulting in autoantibody production.
And why does that matter clinically?
Because in rheumatoid arthritis, the immune system is overreactive. By slowing lymphocyte division, you calm down the hyperinflammatory cycle. Also, keep in mind that it has a very long half-life, around 14 to 18 days. plus enterohepatic recirculation, meaning it stays in the body for months. That's why it's teratogenic and absolutely contraindicated in pregnancy. Even if a patient stops the drug, enough can remain in the body to harm the fetus.
So, what do we do if someone wants to get pregnant?
We have to actively wash it out with cholestyramine, then check levels to make sure the drug is gone. Monitoring includes CBC, CMP, LFTs, BP, and pregnancy testing.
Now, what about the other CS DMARDs, sulfasalazine and hydroxychloroquine?
These are used when the cost is a concern, or combined with methotrexate for better outcomes. Sulfasalazine is broken down into sulfapyridine plus 5-ASA. Sulfapyridine decreases interleukin 1, interleukin 6, interleukin 12, TNF, and reduces T and B cell proliferation. And hydroxychloroquine has an unclear mechanism of action in rheumatoid arthritis, but we know it raises lysosomal pH, making it harder for cells to process antigens.
What's the big toxicity warning with hydroxychloroquine?
Retinopathy. The drug stores in retinal tissues and over time causes blurry vision. It's dose and duration dependent and thankfully reversible. Hence, why patients need annual ophthalmology exams.
So for sulfasalazine, we keep in mind GI upset, leukopenia, reversible male infertility, but it's safe in pregnancy. And for hydroxychloroquine, we think about retinal toxicity. Let's talk about the classic triple therapy.
That's methotrexate, sulfasalazine, and hydroxychloroquine. It's used for moderate rheumatoid arthritis, especially when cost is an issue or biologics aren't accessible.
All right, let's say that our patient, Arthur, is already on methotrexate and it isn't enough. What's our next step, Farah?
Now we move to biological therapies. They are powerful monoclonal antibodies that target specific immune pathways. Super effective, but also expensive and associated with more serious side effects.
First, let's keep in mind TNF alpha drives so much of our inflammation. It stimulates pro-inflammatory cytokines, IL-1 and IL-6, increases MMPs causing cartilage and bone destruction, boosts TRANK-L, which results in osteoclast activation, and it upregulates endothelial adhesion molecules, pulling leukocytes into joints. Basically, TNF alpha fuels the entire RA fire. So we built a whole class of drugs just to block it.
Exactly. The anti-TNF agents, the big three being adalimumab, infliximab, etanercept.
So let's start with adalimumab. I call her Adel. She's a fully human monoclonal antibody. She's quite a low-maintenance gal, given subcutaneously every 2 weeks. Adel can be used alone or with methotrexate, and she has low immunogenicity. And biosimilars exist because it's so widely used.
Now we have Adel's brother, Felix, or infliximab. He's a bit special, being a chimeric monoclonal antibody, part human, part mouse. Because he's chimeric, he's more immunogenic, so we must give it with methotrexate. We give Felix via IV with scheduled infusions, and as with all infusions, we want to keep watch for infusion reactions, fever, chills, and urticaria.
Now we have etanercept, or Ethan. He's a soluble TNF receptor fusion protein that's given subcutaneously. He binds TNF alpha and TNF beta and neutralizes them. Keep in mind that these drugs suppress immunity, so screening is a must.
Exactly. Before starting any TNF alpha inhibitor, we check for tuberculosis via TST or IGRA plus chest x-ray, hepatitis B and C, and we make sure the patient is up to date with all their vaccinations and no live vaccines are taken while on therapy. If latent TB is present, we treat with isoniazid before starting the Biologics DMARDs.
What about someone who already has TB or is at a very high TB risk?
Then we avoid anti-TNF drugs because they can reactivate TB. Instead, we use non-TNF biologics.
Rita, or rituximab, or Roxy, targets CD20 on B cells, which leads to B cell depletion. So it reduces autoantibody formation, like RF and anti-CCP, and decreases antigen presentation.
To give it safely, we premedicate with methylprednisolone, acetaminophen, and antihistamine. Because infusion reactions, urticaria, hypotension, and angioedema can occur.
And screening is the same as before, TB and hepatitis B, plus regular monitoring every 3 months. Now we have tocilizumab, or Tala. She targets the IL-6 receptor. Remember that IL-6 increases acute phase proteins and stimulates osteoclasts, so blocking it helps to prevent bone injury. Finally, tocilizumab can be given intravenously or subcutaneously.
We can't forget about abatacept, who I've named Abigail, a T-cell activation blocker. It blocks co-stimulation between APCs and T-cells. T-cells need 2 signals to activate. Abatacept competes for the interaction between CD80-86 and CD28, stopping the second signal. No second signal equals no T-cell activation.
Can we combine these non-TNF biologics with methotrexate?
Yes, in fact, combining them often increases efficacy.
Okay, Farah, let's wrap up the DMARD family with the last group, the JAK inhibitors.
These are the targeted synthetic DMARDs or TS DMARDs. They're different because instead of blocking cytokines outside the cell, they stop the intracellular signaling that cytokines use to activate inflammation.
And the pathway they target is the famous JAK-STAT pathway, right?
Exactly. JAKs are intracellular tyrosine kinases. Normally, when a cytokine binds its receptor, JAK phosphorylates STAT. Then STAT moves to the nucleus, then inflammation genes get activated. JAK inhibitors block this step, so you get decreased IL-2, IL-4, IL-6, IL-7, IL-15, and IL-21 signaling, basically a broad drop in immune activation.
And the nice thing is, they're administered orally.
Yup, huge advantage.
So what are the main drugs?
There are a few. We have tofacitinib, whom I like to call tufibinjak. Get it? Because tofacitinib is a JAK inhibitor, tufibinjak.
Okay, how about we just explain the drug?
Anyways, tofacitinib, the first JAK inhibitor ever approved. Tofacitinib inhibits JAK1 and JAK3, so it's less selective and may cause more adverse effects. The more selective JAK1 inhibitors include upadacitinib, padmabinjak, which is JAK1 selective and better tolerated. We also have filgotinib or filbinjak, also JAK1 selective, not FDA approved yet, but used in some countries. Remember, Leen, more selectivity equals fewer side effects.
So, Tufi, Padma, and Phil. That's a big family. Anyways, these drugs are powerful, but they come with warnings. The FDA issued a box warning because JAK inhibitors, especially tofacitinib, increase the risk of major adverse cardiac events, malignancy, venous thromboembolisms, and serious infections, including herpes zoster reactivation. So we avoid them in high-risk patients, older adults, smokers, people with cardiovascular risk, history of cancer, etc. So what do we monitor with JAK inhibitors?
Before starting, we want to get CBC, lipids, TB, HBV, HCV screening, and hemoglobin, ensuring it's equal to or above 9. During treatment, we do CBC every 4 to 8 weeks, LFTs every 3 months, lipids every 3 to 6 months. Also update vaccines, especially shingles, before therapy.
And where do they fit in the treatment ladder?
They're not first line. ACR guidelines say use JAK inhibitors only if TNF inhibitors are contraindicated or ineffective.
Here's a quick recap. First, we discussed NSAIDs. They inhibit COX-1 and COX-2, which decreases prostaglandins, decreasing pain, fever, and inflammation. They do not slow disease progression. They're divided into 2 classes, non-selective, like ibuprofen and naproxen, which cause GI ulcers and renal issues, and selective COX-2 inhibitors, which are associated with higher MI risk because of unopposed thromboxane.
Then we move to glucocorticoids that inhibit phospholipase A2, which shuts down entire arachidonic acid pathway. They are used as bridging therapy until DMARDs begin working. Now, for adverse effects, they cause hyperglycemia, weight gain, osteoporosis, infections, mood changes, and HPA suppression. They're used up to 3 months and can be injected into joints.
Then DMARDs, the core of RA treatment. These include CS DMARDs, such as Methotrexate. It's the first-line anchor drug. Its mechanism of action is DHFR inhibition and increasing adenosine, which is its main action. Its adverse effects include hepatotoxicity, bone marrow suppression, stomatitis, pneumonitis, and teratogenicity. Given with folinic acid, leucovorin, not folic acid, and it's avoided with NSAIDs due to decreased clearance. We also have leflunomide. This one inhibits DHODH, which decreases pyrimidines and decreases lymphocyte proliferation. It has a long half-life, plus it undergoes enterohepatic recirculation. It's teratogenic, and it requires cholestyramine washout. Then we have sulfasalazine. It decreases IL-1, IL-6, and TNF. Its adverse effects include GI upset, leukopenia, and reversible male infertility. It's the only drug from this class that's safe in pregnancy. Lastly, we have hydroxychloroquine. It raises lysosomal pH, and its adverse effects include retinopathy, so we do annual eye exams. The triple therapy was methotrexate, sulfasalazine, and hydroxychloroquine.
Biologic DMARDs, anti-TNF, first choice if methotrexate fails. Adalimumab, Adel, which is fully human and given subcutaneously. Infliximab, Felix, which is chimeric, given IV, needs methotrexate to reduce immunogenicity. Etanercept, Ethan, which is a soluble receptor fusion protein and given subcutaneously. Screen before starting for TB, hepatitis B, hepatitis C, and vaccinations, no live vaccines. Avoid anti-TNF, inactive or high-risk TB, so choose non-TNF biologics instead. Non-TNF biologics include rituximab, Rita, which is an anti-CD20, which causes B-cell depletion, so we pre-medicate. Tocilizumab, Tala, which is an interleukin-6 receptor blocker. Abatacept, which blocks the binding of CD80-86 to CD20, preventing T-cell activation. They're often combined with methotrexate.
TSDMARDs targeted synthetic, they're the JAK inhibitors. They block JAK-STAT signaling, decreasing multiple cytokines. They're oral agents. Their examples were tofacitinib, which inhibits JAK1 and 3, so it causes more side effects, and upadacitinib and filgotinib, which are JAK1 selective. It has FDA-boxed warnings because they increase major adverse cardiac effects, malignancy, venous thromboembolisms, and serious infections. While using these drugs, we monitor CBC, LFTs, lipids, and we screen for TB, HBV, HCV, and we update vaccines. Goodness, that was a lot, huh? Why don't we take one or two questions to really solidify this metric ton of information?
Sounds good. Here's one. A 54-year-old woman presented with signs and symptoms consistent with an early stage of rheumatoid arthritis. The decision was made to initiate NSAID therapy. First, which of the following patient characteristics is the most compelling reason for avoiding celecoxib in the treatment of her arthritis? A. History of alcohol abuse. B. History of gout. C. History of myocardial infarction. D. History of osteoporosis. Or E. History of peptic ulcer disease.
And the answer is C. So celecoxib is a COX-2 selective inhibitor. Although the COX-2 inhibitors have the advantage over non-selective NSAIDs of reduced gastrointestinal toxicity, clinical data suggests that they are more likely to cause arterial thrombotic events. A history of myocardial infarction would be a compelling reason to avoid a COX-2 inhibitor.
Good work, Leen. All right, next question. So the patient's disease was adequately controlled with an NSAID and methotrexate for some time. Her symptoms began to worsen, and radiologic studies of her hands indicated progressive destruction in the joints of severed fingers. Treatment with another second-line agent for rheumatoid arthritis was considered. Which of the following is a parenterally administered DMARD whose mechanism of anti-inflammatory action is antagonism of tumor necrosis factor? A. Cyclosporin. B. Etanercept. C. Penicillamine. D. Phenylbutazone. E. Sulfasalazine.
I think it's B. So etanercept is a recombinant protein that binds the tumor necrosis factor and prevents its inflammatory effects.
Wow, that was a lot. Luckily, if we keep the names in mind, as well as the adverse effects, it becomes significantly more tolerable. Great job, Leen.
Thank you. And thank you all for tuning into PodBites. We hope this episode has made DMARDs a little less of a pain to memorize, and we hope to see you next time.
Make sure to follow PodBites for more short, high-yield episodes where we turn intimidating topics into something you can actually enjoy.
Until next time, stay curious, take care of yourselves, and eat a pear.